A quick hello before we dive in. My name is Dr. Michael, a practicing GP here in Auckland. I help international medical graduates prepare for the NZREX clinical exam through focused OSCE tutorials. My sessions include small group practices and personalized one-on-one mock exams with detailed and practical feedback to help you build confidence in communication, clinical reasoning, cultural safety, and managing those time stations. If you're on the journey towards registration and practicing in New Zealand, you're in the right place. You can find more information about my courses and upcoming sessions on my website. Let's get started with today's topic. Alright, now that we've covered the course structure, let's talk about something really important. The basic PMAF-TOSA framework works for almost every single OSCE station, but different specialties require small adjustments. Good candidates don't memorize separate scripts for each specialty, they keep the same structure and then they fine-tune it depending on the systems involved. Let me walk you through how I think about special history in a simple and practical way. For ENT cases, I still use my course structure, but I zoom in on symptom clusters. For ear complaints, I always screen for pain, discharge, hearing loss, tinnitus, and balance or vertigo symptoms. For nose cases, I look for obstruction, epistaxis, discharge, and whether it's clear, purulent, or bloody, sinus pressures, or facial pain. For throat disorders, asking pain on swallowing, difficulty swallowing, those changes, a foreign body sensation behind the throat, or persistent cough. Now here's where you score well in OSCE, the red flags. ENT cases, red flags are very important, so asking importantly about prolonged hoarseness, progressive dysphagia, unilateral persistent symptoms such as unilateral hearing loss or unilateral tinnitus are urgent referrals to ENT, and especially unexplained weight loss as well, which are pretty important as a red flag for every single OSCE station. Those are the things examiners are specifically listening for, and don't forget asking about functional impact that we talked about before. If the patient is a teacher, singer, or even a public speaker, voice problems are huge for them. That's how you show patient-centered thinking. Now for eye cases, the ophthalmology cases, your first job is to decide, is this urgent or not? So most of the time I focus on vision loss, is it sudden or gradual? Is there any pain, is redness? Is there any discharge, photophobia, any floaters or flashing of lights, which may suggest retinal detachment? One very high question I use is, did the vision change first? Or did the redness and the pain come first? That helps separate from retinal emergencies from inflammatory causes. I always clarify, is it in one eye or both eyes? Do you use contact lenses? Is there any recent trauma to the eyes or possible chemical exposures? Specific red flags to look for in eye cases are sudden painless vision loss, painful red eye with reduced vision, photophobia with visual changes. That's how you think like a safe doctor. Now for gynecology cases, I know that many candidates struggle with. I try to expand the PMAF-TOSA into 3 extra areas. So the first area will be menstrual history, the second area will be sexual history, and the third area will be obstetric history. Now I want to talk about the menstrual aspect. So we try to ask specific questions to figure out what the period is like. We ask specifically for last menstrual period, the cycle length, the regularity, the amount of flow, any clots, any pain, any intermenstrual bleeding, or any postcoital bleeding if the woman is sexually active. Now for sexual history, I want to know about the partner. Is there any protection that's used? Is there any possible STI risk or any pain during intercourse? And almost always consider pregnancy in any reproductive age woman. That is very, very important, and never forget that. Now for antenatal and obstetric cases, obstetric is slightly different. You're thinking about 2 patients, the mother and the baby. I structure it like this. So we confirm the gestational age, we want to confirm the last menstrual period, we want to know the scan dates, when was the last time the patient had a scan, is there any good fetal movements, then review past pregnancies such as any previous miscarriages, terminations, any C-sections in the past, or any complication that might have arisen from previous pregnancies. So the current pregnancy risk is something to know. Is there any gestational diabetes? Is there any hypertension? Is there any current bleeding or any signs of infection? Examiners love that. Now coming to pediatrics. In pediatrics, you're speaking to the parent, so the dynamic changes. I always start with how old is your child? Were they born at term? Was there any complication at birth? And then talking about the feeding. Are there good wet nappies daily? Are the bowel movements okay? And about the developmental milestones. Ask specifically regarding to the child's age and check if the mom is concerned about any aspect of the developmental progress. And last importantly, immunization status are super important in pediatric cases. One powerful question that you can use to ask the parent: what's worrying you most today as a parent? So you know the parent's concern. That opens everything that you need to know. For sick children, always screen for fever, any signs of rash, any shying away from lights, neck stiffness which may suggest meningitis. How's the appetite? Is there any decrease in the urine output or any behavioral changes like becoming more irritable or becoming more lethargic? If they are very young, feeding and wet nappies are your lifeline indicators. Psychiatry cases are quite different. They do come up quite often. Psychiatry needs a deeper emotional structure. You still get the background, but you go deeper into the presenting symptom. If the patient presents with low mood, you want to check for the sleep, appetite, energy, concentration, and hedonia. Then you assess the risk. You want to check if there's any thoughts of self-harm or suicidal thoughts, or possible harm to others and self-neglect. Asking about past psychiatric history are also important. Any history of substance use? Any social support present? How's the patient functioning and the current occupation? And always assess risk before moving on. Safety is first in psychiatric cases. And here's the big message. Specialty cases don't require new frameworks. They require sharper thinking within the same framework. If you master your core structure and then adapt intelligently, you will never feel lost in an OSCE station. That's the difference between memorizing and understanding. Now I hope that helps, and I'll see you in the next episode.